Good to be back. I was presenting this morning on the intersection of medical comorbidity and mood disorders. And again, just a call out to Ben and the entire team behind the scene for bringing us together as colleagues and having this opportunity for knowledge exchange. And at the end of the day, it's what helps us help our patients and our families more. And I don't think anyone needs to be convinced this has been a difficult time for everybody. And it's certainly been a very difficult time for people who already have pre-existing mental illness. This morning, I made reference to the fact that if you have a mood disorder like bipolar disorder, you're at greater risk of contracting COVID and its complications. So this is it's been quite a time. I think we're all looking very much forward to this being in the rearview mirror. We're going to speak to the topic that, quite frankly, if I was, and I have been asked many times, what's my most favorite topic in psychiatry? It really is bipolar disorder. In fact, it's what actually attracted me to psychiatry, the complexity and the art of bipolar disorder. And I certainly, in fact, would say that to this day and many years into my career, meeting people who are affected by bipolar disorder reminds me, I think it is still the most complicated mental illness. I really believe that with respect to its phenomenology, certainly its pathogenesis. Mother Nature doesn't make it too easy for us in terms of making the diagnosis. It can be very, very difficult, even after careful and comprehensive assessment. And then, of course, trying to find the right treatment to get people on the right track so they get their lives back is certainly no easy task. With that, what I'd like to do is begin the presentation. You see the title, The State of the Art in Screening and Diagnosing and Treating Bipolar Disorder. And this is a disclosure of organizations I work with in different capacities. And this is the objectives. We're going to say a fair bit about the bipolar spectrum. We'll say a couple of words about bipolar 2 disorder. I think bipolar 2 disorder is often overlooked, not just in terms of our professional meetings like this meeting herein, but also it's a diagnosis just simply because of its more subtle presentation that has often been misdiagnosed at a rate much higher than bipolar 1. And then we're going to talk about some screening tools and diagnostic approaches to bipolar disorder, and we're going to move into some treatment options. And I can say we actually have some newer treatment options now for bipolar disorder just around the corner. So that's pretty interesting, and we'll certainly speak to that. Now, we don't have the mechanism where we have, when I had originally created these slides, I had, I've certainly been accused of being a daydreamer on more than once. And I had a daydream that we're going to be in person. So I was going to pose this to you all in person, but that's okay. We can just do it virtually. And this is a couple of questions. Which of the following is true? Bipolar 2 disorder is a milder manifestation of bipolar disorder. Is that true? Next one. The transition rate from major depressive disorder to bipolar disorder is approximately 1 to 2% per year. In other words, what percentage of people transition from an initial working diagnosis of MDD to bipolar each year of prospective follow-up? Next one. Antidepressant mobilization of hypomanic symptoms should not be considered as evidence of bipolar disorder. Is that true? And finally, bipolar 2 disorder has a lower diagnostic agreement among experts than major depressive disorder. Okay, so we'll come back to this at the end of the presentation. Here's another question. Just get those the mind going here. Which of the following is false? Lumateperone is effective in the treatment of bipolar 2 depression. Cariprazine is effective in bipolar depression with and without mixed features. Which one's false? Lurasidone is effective in bipolar depression without mixed, but not in persons with mixed. Next one. Major depressive disorder with mixed can be treated with second-generation antipsychotics. So which one's false? And again, we're going to come back to this through the program. One or two more just to get us going. Psychostimulants are demonstrated to destabilize. Which of the following is true? Psychostimulants are demonstrated to destabilize bipolar disorder when compared to placebo. In other words, they destabilize our patients versus placebo. Lamotrigine is FDA approved for bipolar depression. C. All second-generation antipsychotics proven effective in depression work in both bipolar 1 and bipolar 2 disorder. And finally, antidepressant monotherapy in BP2 may be safe and effective. Which one's true? Last one. Which one of the following agents has greater efficacy in bipolar depression? Cariprazine, lumateperone, lurasidone, or no significant difference? Okay, we'll come back to that. So let's begin, if we can, with a starting point in the conversation. And the starting point in the conversation for me with bipolar disorder, at least as a clinician, is getting the diagnosis timely and getting the diagnosis accurate. We're going to come back to that point in just a moment. What we all know is that the phenomenology of bipolar, and for that matter, any mental disorder, is not specific to any one condition. So we know that the phenomenology of bipolar disorder cuts across many different psychiatric disorders. What we also know is that bipolar disorder has extraordinary rates of psychiatric and medical comorbidity. For example, recently I looked at this literature and I summarized it in an article, and it turns out that 50% of people who have bipolar disorder have 3 or more other psychiatric conditions. So we call that polymorbidity. So 50% have 3 or more other concurrent conditions. And every clinician has full knowledge of how common this is, as well as the type of disorders. They include, but they're not limited to, alcohol and substance use disorders, anxiety disorders, certainly binge eating disorder, ADHD, and as well, let's not forget about below the neck. People have extraordinary rates of medical comorbidity. This morning, we focused a lot on cardiometabolic disorders, how they differentially affect people who have bipolar disorder and other conditions. And one of the pop quizzes that I didn't put into my audience response questions is, what's the most common neurologic disorder in bipolar? And the answer is migraine headaches, which are really, really common. In fact, we did a survey many years ago. We found that as much as 20 to 60% of people who have bipolar 2 disorder actually have migraine. Let me, in fact, just show you this slide, which has been showing now for a few minutes now. This is a genetic study. And this study, which looked at genetics, more specifically SNPs, single nucleotide polymorphisms in large samples, concluded that there were allelic variants in genome-wide association studies that were common across bipolar, major depression, ADHD, borderline personality, which I thought was quite interesting. And then it got me thinking, what exactly is this telling us? Well, what we do know is that people who have bipolar disorder have cognitive difficulties. Obviously, that's a complex topic, but beginning with impulse discontrol, but as well as other atoms of cognition like memory deficits, attentional problem, and processing speed. They also have problems with circadian rhythms, have problems with hedonic tone, have problems with terrible anxiety, and this is not unique to the condition. The most common personality disorder that's talked about, at least in bipolar disorder, is borderline personality. This condition is characterized by affective instability, cognitive impulsivity, behavioral impulsivity, many features that overlap. In fact, it's been documented that 70 to 80% of people who have bipolar disorder, 70 to 80%, have borderline traits. About 20% meet criteria for borderline personality disorder. So not to confuse, about 70% have borderline traits and about 20% meet the criteria for borderline personality. So very, very common. So the reason I'm bringing this up is not so much to get lost into the weeds about comorbidity and so on, but for me as a clinician, I've had through my clinic tens and tens and tens of thousands of people who have bipolar disorder since I originated the clinic. And the usual narrative is the patient's referred for depressive symptoms because depressive symptoms are the index presentation, the first presentation of bipolar in most affected persons. And it's the predominant presentation of the illness longitudinally. And then I take a history, what I call deep in vivo phenotyping of the patient's phenomenology. And then I find out in my 25 or 30-year-old patient or 22-year-old patient that they had some features that seemed a little bit like ADHD when they were a kid. And there was some drugs and alcohol somewhere in the past, and they had a lot of anxiety. And then I find out they have a history of trauma. And then once I hear about their relationships and I hear about their work history, there's some elements here of personality disorder, or at least some traits of personality disorder. And it's often difficult to suss out bipolar disorder. And bipolar disorder doesn't just share genetics and shares underlying brain substrates, but obviously shares a tremendous amount of phenomenology. So I think we begin with, this is a diagnosis complicated to make, and comorbidities are not just common, but they can often obscure the underlying diagnosis. Keep in mind, in many cases, these are not diagnoses of exclusion. Obviously, major depression and bipolar are diagnoses of exclusion, but not ADHD or borderline and so on. So I sketched this diagram just to provide a very simple heuristic, a simple conceptual framework to think about how DSM-5, which we received in 2013, was a transformational shift away from DSM-4-TR insofar as DSM-5 adopted what many would call a neo-Krepelinian approach. In other words, rather than seeing mania, mixed states, and depression as fitting neatly into discrete buckets, the decision was made, I think a wise decision by DSM-5 authorship, to supplant, that is to replace that categorical definition with this continuous conceptualization. And when we look at people who have bipolar mania, which is of course essential for the diagnosis of bipolar 1 disorder, the great majority of those people have some degree of depressive symptoms woven into the tapestry of mania. Conversely, when you look at people with depression, a very large percentage of those people have hypomanic symptoms woven into the tapestry of that depression. You all know that the so-called mixed features specifier during a depressive episode applies to both people who have bipolar 1 and 2, and as well, people who have major depressive disorder. It sometimes gets a bit confusing because most people, when told a patient has hypomanic symptoms, would automatically conclude the patient has bipolar disorder. But keep in mind, hypomanic symptoms do not equal bipolar disorder. Hypomanic episodes or manic episodes do, but not symptoms. And symptoms can affect people with either bipolar or unipolar disorder. Now, one of the questions that was posed is around the inter-observer agreement. And I put this slide in just to show you empirically how this was documented during the DSM-5 field trials. And I don't think these results are going to surprise you, although I think one result might surprise you. I think that just about every healthcare provider is fully aware that bipolar 2 disorder is a more difficult diagnosis to make than bipolar 1, largely because the excursion into hypomania cross-sectionally is not as severe as mania is. And of course, mania defines bipolar 1 disorder. I should emphasize that bipolar 1 disorder is defined by mania, but of course, people with bipolar 1 can have hypomanias. By definition, bipolar 2 is alternation of hypomanic episodes with a depressive episode. So clearly what we have here is bipolar 1 disorder having higher inter-observer agreement than bipolar 2 disorder. Some of you might be saying, how do we benchmark these numbers? Like what's considered reasonable agreement? Well, we like to see scores of at least 0.4. So bipolar 2 disorder just gets across the line in that reasonableness. But here's the part I don't think it made much press that I always found very interesting, that major depressive disorder has an inter-observer agreement of 0.28, even lower than bipolar 2 and bipolar 1. That surprised a lot of people. And I think that's in part because the boundaries are quite fuzzy between major depressive disorder and many other related conditions. but I'm focusing on bipolar 1 and bipolar 2. But here's something else I take away from this slide. By definition, major depressive disorder is a depressive illness. By definition, BP1, BP2, you have to have mania and hypomania, but as we're going to talk about a lot throughout this program, depressive symptoms and episodes dominate the illness course. But when you look at this slide, it seems as though the more depression prone the patient is, the less likely we agree on the diagnosis. They're probably going to be missed. So it seems as though bipolar 2 is missed more than bipolar 1. Bipolar 2 has more depression than bipolar 1. And major depressive disorder is missed more than bipolar 2. And major depressive disorder has even more depression. So whenever you see depressed patients who present to your office, they're there because of distress related to their symptoms, we've got to be screening for bipolar disorder. Now, the age at onset of bipolar disorder, it's been debated. Some people think it's a bimodal age at onset. Data are suggesting it might be trimodal. In other words, there's 3 peaks. One peak, absolutely the biggest peak of all, is around 16 to 18 years old. There's another peak at around 23, 24, and another peak at around 42 to 44. Taken together, what I always tell people is the 75-25 rule. That 75% of people with bipolar disorder declare the illness observably to their clinicians before the age of 25. So that's where this illness largely begins. Now, the age at onset is a very interesting issue because it depends on how you define it. But here's a study I wanted to share with you. It really speaks to the intersection of trauma in childhood and the onset of bipolar disorder. Despite the fact that bipolar disorder is a highly heritable condition, in fact, the heritability is around 70%, Bob Post has shown that if you're a victim of childhood maltreatment, especially when you have extensive childhood maltreatment, the age at onset is significantly younger. So red on this heat map denotes onset under the age of 13. And what you're looking at on the x-axis is total childhood abuse. There is a dose effect here. The more abuse, the earlier the age of onset, and that interacts with genetics. So family history clearly is linked to onset of bipolar disorder, but childhood abuse and the more of it brings the age at onset even lower. And what's interesting is that when you look at the age at onset of bipolar in the United States and Canada, it's very different than Europe. In Europe, the age of onset for bipolar seems to be 5 to 10 years later than it is in North America. And what's interesting is that in North America, people with bipolar disorder report higher rates of trauma. What is also reported in North America, which is different than Europe, is a higher rate of assortative mating. In other words, there's a greater likelihood that both parents have mental illness in North America, while in Europe, it's a greater likelihood that only one parent has a mental illness. So this is, I think, a very, very interesting conversation. And by the way, trauma in bipolar is not just common, affecting 50 to 75% of people who respond to these types of surveys. But when it happens, it changes the phenomenology. These patients tend to be more mixed. They tend to have more rapid cycling. They have more comorbidity like personality disorder and anxiety disorders and drug and alcohol misuse disorders. They have more suicidality. And they also, in fact, are more likely to exhibit suboptimal response to conventional treatments. Just a reminder, I showed this morning, this is now published, that people with bipolar and depression have greater risk of infection, hospitalizations, and mortality due to COVID, even after we adjusted for all the pre-existing conditions that we all know put people at risk. And I bring this up because for me, this was a paper we published just a few months back, Felicia Saban from my team, because we're talking about not just simply, trying to reduce morbidity, we want to reduce mortality. And the mortality rate in bipolar disorder is significantly elevated. The most common cause is cardiovascular. And we know that our patients are also dying at a very young age. In fact, they lose 15 to 20 years of life. So when we talk about bipolarity, we're talking about not just managing above the neck, but we're also talking about managing below the neck. Now, I want to come back to this issue of diagnosis because, again, I think this is the biggest challenge we have in 2021 is getting this diagnosis made timely and accurately. So remember one of the questions asked about transition? So transition means that your initial diagnosis was MDD, but now you're being re-diagnosed as bipolar. And it's interesting because this is something that I think people sometimes forget about because depression is the index presentation. It's quite possible that over a period of time, Mother Nature playing a game of poker with us doesn't show the card of mania till a bit later. And it's been shown in a couple of studies now, in fact, quite a few studies, observational longitudinal studies that have been conducted over 5, 10, 15, 20 years, that the rate of conversion is around 1 to 2% per year. So very easy mathematics. If we had 100 patients in our office with depression today, no mania, no hypomania, their chart diagnosis is major depression, and we asked all 100 patients to come back in 10 years' time for a follow-up appointment, I know it's a long time, between 10 to 20 of them now have bipolar disorder. The mania is now manifesting. And where that presents itself to me is patients will often be referred with so-called treatment-resistant major depression, and many have that, but many don't. Many have bipolar disorder that's been misdiagnosed as major depressive disorder for quite some time. A different narrative that I've heard so many times over the years is a patient will begin an antidepressant because their diagnosis is depression, and things are for the most part fine. Maybe they're seeing a therapist or counselor. Then they have an episode come back, and now the medication is not working as well. And now the symptoms, in addition to being depressed, they're very anxious, they're very agitated. So the phenomenology starts to look a little different. And what we're beginning to see now is the emergence of the hypomanic and manic symptoms. Now, with respect to considering a patient who, in fact, may have bipolar disorder, these are, in fact, the considerations that I go through with each of my patients. It's called a probabilistic approach. In other words, we don't have a blood test, we don't have a biomarker or biosignature, so it's based on a good history, deep in vivo characterization. And what we in fact know is that people with bipolar, the 75-25 rule, they typically have an earlier age at onset. They typically have multiple episodes. These are not infrequently seasonally influenced. For women of reproductive age, for reasons not fully understood, bipolar not infrequently will manifest itself for the first time or recur during pregnancy or during postpartum. I think all women with postpartum depression have got to be really carefully evaluated for bipolar disorder. And then when we start to look at the family history, there's a family history loaded for mental illness because this is a highly genetic disorder. But keep in mind, the genetics, which are not well characterized, are not specific to bipolar disorder. That being said, what the GWAS studies, the genome-wide association studies, tell us is that bipolar 1 disorder seems to be a closer genetic cousin to schizophrenia, while bipolar 2 disorder seems to be a closer genetic cousin to major depressive disorder. And there's something about that observation in genetics that kind of rings true to me clinically. With respect to the actual phenomenology, there's no specific symptom of a bipolar or sort of a depressed patient who walks into our office that indicates they unequivocally have bipolar disorder. Instead, we have to take a careful history. That being said, there are some symptoms that are more likely to be encountered in someone who's depressed and has bipolar versus someone with major depression. For example, the person with bipolar relative to someone with major depression is more likely to have psychotic symptoms. Moreover, the person with bipolar is more likely to have atypical depressive symptoms. Just a reminder, atypical depressive symptoms refers to eating more, sleeping more rather than eating less and sleeping less, terrible fatigue, terrible psychomotor retardation, and an incredible sense of reactivity to external slights and so on. Third and finally, mixed features. In other words, mixed features, the presence of hypomanic symptoms during a depressive episode, which can affect both adults with major depression or bipolar disorder, is much more likely to occur in somebody who has bipolar disorder. Now, over the years, I've tried to find a way, a mnemonic or some type of cheat sheet or some type of enabler to assist me at the point of care in a patient I'm encountering who has bipolar disorder that would really tell me they have mixed features. Now, for those of you who have the DSM-5 fully memorized, you would know that the mixed features criteria in DSM is very specific. And what it says effectively is you have a depressive episode and you have at least 3 or more hypomanic symptoms. And it gives a list of symptoms. However, the most common symptoms that are encountered in patients experiencing mixed features are not the symptoms that are in the DSM-5. The most common features during mixed are listed here, and I call them the 4 A's. Someone who comes into my office and they say to me, I've got depression, I'm tired, I'm fatigued, I have no interest in my life, can't, enjoy things. The depressive symptoms are not the dilemma. That's pretty clear. And then they say to me, I'm really anxious and I'm really agitated all the time. And I'm really angry and I'm short fused, I'm snarky, I'm irritable, and I can't focus. My mind's racing. They often ask me extemporaneously, they'll say, do you think I have ADHD? And maybe I need Vyvanse, they'll say. And so when I hear this anxious agitation, this anger, this attentional problem, that doesn't indicate they have bipolar disorder. That tells me that they have a very high likelihood of having mixed features. That gets me really suspicious. And these are the most common symptoms that I encounter in managing patients who have bipolar. So when you see patients with bipolar, ask them about with depression, ask them about the 4 A's. If they have these symptoms, you got to really wonder whether they have bipolar disorder and start to look at this more carefully, because these are the symptoms that are most often encountered. David Muzzina is a colleague of mine, and when David was at psychiatrist, when he was at Cleveland Clinic, David and I set up a common repository where patients who came to Cleveland Clinic or came to my clinic in Toronto, we had identical metrics that patients would complete, and they would be all entered in a common database. And what we did was we harvested some data from the database. And we asked a very simple question. How common is MFS, mixed features specifier, in people with major depression, BP1, BP2? What we found is about a third or so, 35% of people with bipolar disorder have mixed, and about 25% or so, just shy of that, with major depression have mixed. So again, a reminder, many patients with depression can have mixed features. For bipolar disorder, it's a bit more common. And this result, around 35% or so, is a result that has been replicated in part by some other groups. By the way, parenthetically, I'll mention, if you're looking for a most up-to-date guideline for bipolar disorder, I would recommend the Florida Psychotherapeutic Guidelines. They're free of charge. You can download them, Florida Psychotherapeutic Guidelines for bipolar or depression. They were published in 2019, 2020. You can download, and they provide algorithms for selecting and sequencing treatments that is really up to date. And that's something we haven't had from the APA since 2003, since APA has published a clinical practice guideline for adults with bipolar disorder. So now I want to talk about screening tools. Now, when it comes to screening tools, the question is, well, why would I screen for bipolar? I think that's kind of obvious. It's common in clinical practice. Some studies report up to 25% of people in clinical office settings with depression actually have bipolar disorder. So it's common, and you want to screen in a place where the disease might likely reside. And then the question is, what are some of the psychometric, or what are some of the methodologic aspects about a screening tool that you'd like to see? Well, you want a screening tool that the patient can administer. That saves us time. You want it to be brief. You want it to be sensitive. In other words, sensitive to the fact it's got questions that'll pick up the illness, and also that it has good negative predictive value. And what that means is if they screen negative, you're really confident they don't have the diagnosis. Remember, screening tools don't diagnose bipolar. A positive screen raises your suspicion. A negative screen Doesn't quite rule it out, but almost rules it out. In other words, you're pretty confident they don't have it because it's got really high negative predictive value. Now, we have the hypomania checklist. In the last 20, 21 years, we've had the mood disorder questionnaire. And more recently, colleagues and I validated the rapid mood screener. Now, a pushback on some of the screening tools has been that they are perhaps guilty of a bit more false positives than we would like to see. In other words, many colleagues across the country, around the US, around Europe, all around the world have said, I like the MDQ, but a lot of false positives. A lot of my patients with borderline pathology, for example, screen positive on the MDQ. So there was an incentive to maybe go back to the chalkboard a little bit and maybe try to come up and engineer a screening tool that's brief, 6 items is brief, and items that would maybe assist us in keeping what we want, sensitivity, brief, patient administered, but also maybe try to reduce some of those false positives. And we came up with these items, and I think some of these items are why this scale performs quite well. Have you had a time of 6 different periods in the past when you felt depressed? So that's that multi-episodicity, depression before the age of 18. There's that early age of onset. Have you had to stop an antidepressant because it activated you, irritability and hyper? And then these other questions about hypertalkativeness, unusually happy, energetic, and and less need for sleep. And I think that those items, particularly the items that take into consideration longitudinal course characteristics, is why the screening tool performs quite well. And you can download it free of charge from Dr. Google. The article itself in this journal is free. It's open access. You don't need to have a membership in that particular journal. So what I did in a publication fairly recently, just in December of 2020, so it's still fairly up to date, is I wanted to provide a summary of treatments for bipolar disorder. I published this in the Lancet, and so I think all these treatments are available in America. The Lancet's a global journal, but this is all available in America. So on the left, we've got acute bipolar depression. In the middle, we've got acute mania, and on the right is maintenance. Now, I'm not going to go through each one of these. You can just take a picture of it with your phone if you like, or something like that. But what I am going to say is we're probably going to see some movement in this area. First of all, despite the fact that the depressive phase of bipolar disorder is the predominant presentation, we have relatively fewer options for bipolar depression than we do for mania. And by the way, that's not because we didn't try. A lot of the antipsychotics that work in mania don't really work in bipolar depression. Aripiprazole and risperidone didn't work that well. They didn't work. You got other drugs like lorazepam that has been proven effective in bipolar depression, monotherapy and adjunct, but was never studied in mania. Now, one of the surprises that people often have is that lamotrigine is not approved in bipolar depression. That surprises some people. Just a reminder, it's approved as a recurrence prevention drug in bipolar disorder, but not for bipolar depression. Now, part of this is just wordsmithing because the fact is that the FDA granted an indication for recurrence prevention for lamotrigine in bipolar, recurrence prevention, not depression. But for those who have a real eye for the detail, you would know that the recurrence prevention efficacy is most established in preventing depression. I still see lamotrigine as a first-line treatment in bipolar depression, as I see the other L's, lithium and lorazepam. In fact, when I see patients who come to me, they ask me, they say, I've been on all the drugs for bipolar depression, nothing works. I said, have you tried the 3 L's and the C? They said, what's that? I said, lithium, lorazepam, lamotrigine, and cariprazine. And they said, no, I haven't had any of those. And cariprazine is approved in mania and mixed and in bipolar depression. Now, I want to make a comment about the other L, lumateperone. We're going to talk about that in a moment. Lumateperone has been cleared by the FDA, approved for schizophrenia as of December 2019. It's not yet approved in bipolar depression, but it is fully expected to be approved. I don't know for sure, but it's fully expected to be approved in mid to late December by the FDA for bipolar depression. So that'll be a supplement indication to its already existing indication in people who have schizophrenia. So we fully expect lumateperone I guess you could say, to get promoted to the indication category in about 4 more weeks from now. Fingers crossed that'll be the case. I think it will be, but I guess we'll see what we see. The other part I wanted us to mention is that when it comes to managing acute mania, I don't think that's too much of a dilemma pharmacologically. We've got many options. And for maintenance, I do think we underutilize long-acting injectables like aripiprazole. That's a very effective long-acting injectable that we often use not only for people who are non-adherent and are relapse prone, but I have many high-functioning people with bipolar. I've got CEOs, I've got lawyers, people who have bipolar who take their medications religiously every day, who decided to take the long-acting injectable. And, almost a bit of a cliche, they'd rather take the medication once a month than 30 times a month. And so it is an option that I find that more people are willing and open to take than I would have thought maybe 10, 15 years ago in my career. Let's not forget about ECT, which is still the heavyweight champion of the world when it comes to efficacy. And it still is a go-to treatment for patients who have treatment-resistant bipolar depression. I have a few words about antidepressants coming straight up. This is a survey that was conducted and published in the American Journal of Psychiatry in August of 2020 by Greg Ree at Yale. And what he did was he looked at the pharmacoepidemiology of bipolar disorder, not simply cross-sectionally, but longitudinally over the last 20 years or so. And this is in the United States. A couple of points. First, the most frequently prescribed class of drugs for people with bipolar in America are the second-generation antipsychotics. I suspect that's in part because they have expanding indications there, and there's been a lot of promotional activity going on in that area as well. What's interesting is that antidepressant medications was the second class of medications. I find that interesting because antidepressant medications are not approved in bipolar disorder. In the Florida guidelines, they're actually a fourth-tier recommendation. Notwithstanding, they are handsomely represented in this big survey, second on the list. And the use of antidepressants has been going up and up the last 20 years in bipolar. But here's the third and final point. I think it's the zinger. And as what Greg Ree showed in his analysis was not only does antidepressant prescription going up, but antidepressant monotherapy utilization of bipolar is going up. That left me somewhat bemused, because antidepressant monotherapy is not typically what we recommend. In fact, that's where there's been more agreement than disagreement. In this world we're in right now, what the world's like right now, where no one can agree on anything, including the day of the week, we agreed on something, and that is antidepressant monotherapy should not be prescribed in bipolar disorder. Well, turns out it's happening a lot. So where does the truth lie? Where does the truth lie? Does it lie in academic recommendations? Does it lie somewhere in real-world clinical practice? Or like most dialectics, is it somewhere in between? We'll come back to this in just a moment. One of the key aspects, though, when we prescribe antidepressants, and this is a bit of a surprise to some people, is that antidepressant medications can clearly mobilize hypomania or mania when you prescribe them in a person with depression. But the actual frequency of that event is quite low. In fact, the number needed to harm, how many people do you need to treat for that to occur, is around 150 to 200. 150 to 200. I mean, that's not very common, but it could occur, but not very common. And I think you need to look at bipolar 1 and bipolar 2 very separately. It turns out when you juxtapose bipolar 1 next to bipolar 2, and you look at the risk of destabilization, it's barely detectable in BP2. You see it in BP1 more than in BP2. So taken together, antidepressants as monotherapy, probably a no-no in bipolar 1 depression, but in bipolar 2 depression, we're going to come back to this. There may be a role in some cases for antidepressant monotherapy. If a patient, however, came to me with any condition, bipolar 1, bipolar 2, and they said, I have a history of switching on antidepressants, I probably wouldn't use antidepressants. If the patient has hypomanic symptoms while they're depressed, mixed features, I probably wouldn't use antidepressants. And Mark Fry showed many years ago in this analysis that even if you have a little bit of hypomanic symptoms in your depression, you're more at risk of TEM, treatment emergent mania. So treatment emergent mania on an antidepressant is more likely to happen in people who've got a little bit of mixed features versus people who don't. So I wouldn't typically use an antidepressant in someone who's rapid cycling, who has a history of destabilization, especially frequently doing so, or someone who's got mixed features. So that's a key point. Staying on the theme of antidepressants, remember what I said earlier. Many people who are diagnosed with depression and receive antidepressants don't benefit. They don't benefit for one of two reasons. One, the depression is uncooperative, or two, the diagnosis is not depression, it's bipolar disorder. And this is a report out of Taiwan where they showed that if you have so-called difficult to treat depression, that's really code for it took a couple of antidepressants to get this thing right. There's a much greater likelihood you're going to be transitioning to bipolar disorder. Remember, my transition is 1% to 2% per year. Remember that? Well, in this survey, what they found over a period of 7 to 9 years, about 20 to 25% transition into bipolar if they don't respond to antidepressants. So when you see a patient with depression, especially when they have the 4As and or they say, I've had multiple antidepressants, they don't work or make my life worse, that gets you really suspicious because we're really just like lawyers in a courtroom trying to build the case beyond the reasonable doubt that this person may have underlying bipolar. Now, this is in fact data from J. Amsterdam at Penn, and this has been replicated with venlafaxine and also with sertraline by Loy Altshuler before she passed away at UCLA. And this takes some people, this kind of jolts people sometimes because, again, antidepressant monotherapy has been frowned upon, highly recommended against in the field, but it's happening not infrequently in the general population. Turns out the data might support that behavior in bipolar 2 disorder, not bipolar 1. And these are data showing that in bipolar 2 disorder, people prescribed an SSRI did not destabilize at a very high rate. In fact, had a very good outcome, an even better outcome than they had on lithium or placebo. And again, we have replication of this with some other antidepressants. So taken together, the idea that you could use an antidepressant as monotherapy in bipolar 2 depression is no longer considered, heresy or some type of anti-establishment behavior. It's actually supported by some evidence. Admittedly, though, it's tricky because a lot of these patients have mixed features. A lot of them have rapid cycling. A lot of them, in fact, have a history of destabilization. And those are three scenarios I would not use antidepressant at all. But the point I wanted to leave you with is that many of you are either knowingly or unknowingly treating an adult with bipolar 2 depression with antidepressant monotherapy. And in many cases, this seems to be okay. This is a bit of a paradigm shift in the field. Now, lithium was first isolated in 1817 by a chemist in Sweden, and lithium still remains in 2021 a gold standard antidepressant and mood stabilizer and anti-manic. It's also an anti-suicide drug. Now, you all know clozapine has been shown to reduce suicidality and schizophrenia. In the world of mood disorders, the only drug that's been shown to lower suicide is lithium. Some might be asking, what about S-ketamine and ketamine? Well, they've been shown to lower measures of suicidality, like ideation, but they've not been shown yet to reduce suicide. And lithium, which is in the drinking water in many parts of the world, has been shown to lower suicide rates when it's in a higher concentration in the drinking water. Very interesting story indeed. So this is a drug we continue to use not infrequently. But the atypicals are without question the drugs that are most frequently prescribed to people who have bipolar disorder. Lurasidone, not effective in mania, but is effective, 20 to 120 milligrams a day in monotherapy or as an adjunct to lithium or valproate in the adult with bipolar depression. And I think we took the lurasidone because it was one of the few drugs that doesn't have a lot of weight gain and a lot of metabolic disruption, which is so common with olanzapine and risperidone and many, many others. And the data were sliced and diced, and we see good response and remission rates that are aligned with a number needed to treat of less than 10, which is considered to be a very relevant clinical significant effect. One other point I should mention just in passing, and Greg Ree's data showed this as well, is that we're seeing a lot less Depakote being prescribed across America, in fact, around the world, in bipolar disorder, in part because it's not very good for depression. And Depakote in depression, is the most common presentation of bipolar. Moreover, Depakote does not have recurrence prevention data supporting its efficacy. And finally, many of you would be aware of the fact that there's been a number of Dear Healthcare Provider letters going out around the world, alerting us to even greater concerns than previously appreciated of teratogenicity, not just neural tube defect, but also, in fact, cognitive problems and behavioral problems. In fact, in England and France, there's been Dear Healthcare Professional letters that went out that told the healthcare providers, you probably shouldn't use it at all if you can avoid it. It wasn't an outright ban, but it was a strong statement about don't use it almost at all in women of reproductive age because of the concerns. Because when I had started in psychiatry, Depakote's teratogenicity risk was estimated around 3 to 4%. That's now gone up to 8 to 14% in some surveys. So that's something to keep in mind. So I got to say, I haven't initiated Depakote in quite some time, to be quite frank. Lurasidone, we did an analysis and we showed, this is one of the audience response questions, we showed that lurasidone is a drug that, yes, it works in bipolar depression, but I sliced the data into those with and without mixed features, and I found that those with and without mixed features both benefited from this intervention. Now, with respect to cariprazine is effective in mania and mixed, but it's one of the few drugs that's also effective in bipolar depression. In fact, only quetiapine would have that claim that it can treat bipolar mania and it can treat bipolar depression. But the hazard of quetiapine is it's very sedating. It can cause a lot of sleepiness, somnolence, and of course, everybody knows it can cause weight gain and metabolic problems. By the way, I was just reading a paper this morning, which I thought was very interesting, where the authors looked at the metabolic risk of using a low dose of olanzapine or quetiapine. So a little dose of quetiapine, like 25 to maybe 75 milligrams, and showed that it can cause metabolic problems. So this is a drug, these are drugs that cause metabolic problems, olanzapine, quetiapine, even at low doses. But cariprazine at 1.5 and 3 milligrams was shown to be effective in patients with and without manic features. Higher doses, 3 and 6 milligrams, have been shown to be effective in patients with mania. Cariprazine's data have been analyzed, and this is a really important analysis showing that it can work in bipolar depression, whether your duration of episode is greater or less than 2.5 months. In other words, it works for long episodes, briefer episodes, people who've had more prior episodes, etc. So this is a drug that has really, I think, taken hold of bipolar depression, been used quite frequently. Now, I had mentioned in passing when I showed you that dashboard slide from my report in the Lancet, the lumateperone, which is not yet FDA approved for bipolar depression, looks like it might get the green light in about 4 weeks from now, just before the Christmas time. And again, I don't know that for sure, but that's what it's looking like it's going to happen. And these are some data that looked at from lumateperone's development in bipolar disorder. And the company Intracellular developed this product not only as a monotherapy, but as an adjunct to lithium or valproate. And what's interesting is that they also studied it in bipolar 2 disorder, not just bipolar 1 disorder. And many might be aware of this, many might not be aware of this, but when bipolar depression trials are conducted, it's pretty rare for sponsors to include bipolar 2. In fact, the only other drug in bipolar depression that was studied with bipolar 2 patients included was quetiapine. And quetiapine showed benefit, as you know, in bipolar depression. Lumateperone included bipolar 1 and bipolar 2 depression and showed benefit in both subpopulations. In fact, the effect size in bipolar 2 disorder turned out to be even greater than bipolar 1 disorder. It doesn't surprise me then that the company that makes this product is also now developing this in major depressive disorder, That doesn't surprise me given what we just seen here. And lumateperone, as you know, is a drug that not only engages 5-HT2A and dopamine at a very low affinity, but also the glutamate system. And that's been shown also in remission data, the clinically significant effect. Now, lumateperone, just like cariprazine, I've had an interest in mixed features for a long, long time. So whenever I, in fact, see these data sets, I always ask the sponsor, can I have the data? Can we run the analysis? I want to see if it works in patients with and without mixed features. And we saw benefit in both of these subpopulations. I don't think I need to convince anybody mixed features is a very complex presentation. And it's a presentation that I would not give antidepressants to. So we really want to know how these agents perform in this particular subgroup, and we have some very nice data there. So if I was to summarize where these second generation antipsychotics all play out on this dashboard, here's how it plays out. You've got lumateperone, again, not yet FDA approved, although I think it will be in 4 weeks, in bipolar 1, bipolar 2 depression as monotherapy or as an adjunct to lithium or valproate, with that caveat that I haven't prescribed Depakote in years for patients with bipolar. Quetiapine also has efficacy in BP1, BP2, but it has that Achilles heel being the weight gain, the somnolence, things like that. Nobody really took the Symbyax, or very few people took the Symbyax, olanzapine, fluoxetine. It's been studied in bipolar 1 depression. Lurazidone's been studied in bipolar 1 depression, and cariprazine in bipolar 1 depression. Although we should not forget that Vraylar, cariprazine, is also shown to be effective in mania in mixed states. Lumateperone and lorazepam were not studied in mania in mixed states, and that doesn't matter because obviously some patients have more, even though they have bipolar disorder, some patients have more depression predominant recurrences, others have more manic predominant recurrences. Now, I'm not going to get into all the side effects of the agents, but this has obviously been an issue that's been a limitation. We have seen weight neutrality with lorazepam, cariprazine, and lumateperone, and that is clearly an advantage. We've also seen metabolic neutrality. There's a little weight with cariprazine, but it's not much. Like the placebo subtract is around half a pound or a pound. Lorazepam and lumateperone and cariprazine are also, for the most part, they are metabolically neutral. Interestingly enough, there's some data for lumateperone and schizophrenia that shows that about a quarter of patients lose weight on this drug. So I'm not saying it's a weight loss drug. That's not my message. My message is it does not cause weight gain. And lorazepam, none, cariprazine, minimal, and all three do not disrupt metabolic and glucose homeostasis. And that's relevant because half of the patients with bipolar have metabolic syndrome. Now, keep going with this. What about neurostimulation? Well, here's some data. We know ECT has been shown to be effective in treatment-resistant bipolar disorder. And as well, we have some data for TMS. And this is some direct current stimulation data showing BP1, BP2 that we have a significant benefit of TMS, this version of TMS. This is the direct current for bipolar depression. So I think TMS, ECT, probably underutilized. ECT seems to be more effective just in terms of clinical impression. And there are data in major depressive disorder where it's more effective than TMS, but something I would certainly consider. When it comes to those mixed features, again, I put this in purposefully just to remind everybody, I would not use antidepressants in people who have bipolar and mixed, which then begs the question, what about a patient with major depressive disorder and mixed, who have those A's? Well, I would still recommend an antidepressant only because we're really in uncertain territory there. We don't have a lot of good data in MDD with mixed. There's been one study with lorazepam showing that it's effective in MDD with mixed as monotherapy, and lumateperone is being developed as a monotherapy in MDD with mixed. In the Florida Psychotherapeutic Guidelines, there is a recommendation that if you have MDD with mixed, you should start with an antidepressant, but keep a close eye on the patient because the antidepressants in MDD with mixed are just not that reliably effective. What about psychostimulants? Do we use those in treating bipolar depression? We have. We also use them to treat binge eating disorder and ADHD and bipolar disorder. So some might be asking, why would you do this? Aren't psychostimulants destabilizing? Well, there's a couple of answers to that. There is no evidence whatsoever in randomized, double-blind, placebo-controlled trials that stimulants destabilize bipolar patients. But we all have patients, or most of us do, who've had some degree of destabilization. So it clearly can happen in some people, especially people who are prone to this or have a history of this or have hypomanic symptoms to begin with and are taking it without a concomitant second-generation antipsychotic or lamotrigine or what have you. This is a chart review analysis you're looking at from Sweden, and what the investigators did is they looked at people who are not taking a mood stabilizer, no mood stabilizer, NMS, or they're taking a mood stabilizer, MS, and they're looking at the percentage of patients who presented with a mania. And it turns out that the people who were taking mood stabilizers, they didn't have any manias, but the ones who were not taking mood stabilizers did. Takeaway message is that when you prescribe a psychostimulant in a person with bipolar, I would first of all treat the bipolar symptoms first to the extent you can. I would add the stimulant to the existing pharmacopoeia for the bipolar disorder. But again, I would not use stimulants in people who have mixed, who are rapid cycling, or obviously patients who are floridly manic. I would not do that. But this is an important point for clarification in the field. Now, just recently, back in May of this year, in the American Journal of Psychiatry, myself and my team, there were about 30 of us, we published the guidelines for ketamine and esketamine. And this is an international guidance, 5 continents represented, because I really felt that this was an important innovation that, like anything else in life, needs guardrails. And we need guardrails in the sense of the practice parameters, the operating procedures, implementation, patient selection, safety surveillance, all these types of things. And I would encourage you to have a look at the article. It was in May, actually, of this year in the American Journal, which is the international guidance on ketamine and esketamine. And we're focusing on bipolar right now. And we, in fact, do have insufficient evidence at this time to make any strong statements in bipolar depression. But we do have data. There are some data. We've published some data on this, showing that it's safe and very effective in many people with bipolar depression. Moreover, it does not cause dissociation or psychosis or mania at a rate higher than we see in major depressive disorder. That's important to know. We've just got a study where we've just started. It's supported by the Canadian government, the Canadian equivalent of the NIH. And what we're doing is we're giving patients intravenous ketamine, multiple doses, to see whether that is safe and effective in bipolar depression. It's a large controlled trial that's being led by one of my colleagues, but it's an exciting possibility that we can offer patients rapid-acting treatments for bipolar depression that tend to be very severe and malignant, often treatment non-responsive, and suicidality. Bipolar disorder has perhaps the highest rate of suicide in psychiatry. It's either bipolar or it's anorexia nervosa. And depends on the study. And we don't really have, I think, treatments that are sufficient. We have lithium, but I mean, lithium's not used very much. And so this would be something that would be exciting if it could do that. But we do have some very nice data for that particular treatment. Okay, let's, if we can, now go back to the questions. Which of the following is true? Bipolar II disorder is a milder manifestation of bipolar. That is clearly not true. And the reason why that's not true is that hypomania is more severe than mania. But depressions are what account for most of the disability. And here's the part that I think makes the point strong. Suicide completion rates are higher in bipolar II than they are in bipolar I. So bipolar II disorder is not a milder manifestation of bipolar. Hypomania is, but not bipolar II disorder. What is true is number 2. The transition rate is about 1% to 2% per year. So just keep that in the back of your mind. If you ever have a patient with depression and they revisit for consultation 2, 3, 4, 5, 6 years later, things aren't going so well, always got to be open-minded to diagnostic reconsiderations. Antidepressant mobilization should not be considered as evidence of bipolar. Yes, it should. Antidepressants don't cause bipolar disorder, they unmask it. So if a patient became hypomanic on an antidepressant, that counts towards the bipolar disorder diagnosis. And bipolar 2 disorder has a lower diagnostic agreement among experts than major depressive disorder. No, it doesn't. It has a better diagnostic agreement than people with major depressive disorder. Which one of these is false? Well, lumateperone is effective in bipolar 2 depression. That's true. Cariprazine is effective in bipolar depression with and without mixed features. That's true. Lurasidone is effective in bipolar depression without mixed, but not in persons with mixed. That is false. It's effective in both subpopulations. And finally, depression with mixed can be treated with second-generation antipsychotics. The answer is yes. Data are very thin on this, but yes is the answer. And just have a look at this in the Florida Psychotherapeutic Guidelines. Which of the following is true? Psychostimulants are demonstrated to destabilize bipolar when compared to placebo. That is false. Lamotrigine, now I'm not contradicting myself by saying some people that could happen, but not compared to placebo in studies. Lamotrigine is FDA approved in bipolar depression. No, it's not. It's approved as a recurrence prevention drug. All second generation antipsychotics proven effective in bipolar work in BP1, BP2. No, they don't. Only quetiapine and lumateperone have been looked at in that way. Antidepressant monotherapy in BP2 may be safe and effective. That seems to be true. Last question for the, we'll open the floor up for any comments or questions that you might have here. And that is, which one of the following agents has greater efficacy in bipolar depression? No difference. They're all effective and they're all first-line treatments now in bipolar depression. But with that little disclaimer, lumateperone is not yet FDA approved. We expect in a month's time that it will be, but we'll wait and see what happens. Take-home messages. Let's get that diagnosis. Let's do screening tools. Be aware of the transition from major depression to bipolar disorder, and let's try to choose treatments that are tailored and personalized to the patient that recognize not just their symptom profile, but also the tolerability and the safety. One final remark is psychosocial treatments. I think that all patients with bipolar require pharmacotherapy, and they also require a heavy dose of psychoeducation. And in many cases, these patients can really benefit from cognitive therapies and mindfulness-based therapies and interpersonal therapies added to some of these other modalities of treatment. So with that, I want to stop and pass over, I think maybe to Ben. Is it yourself or other colleagues? We're going to have, I think, a Q&A session.
It's Kate. All right. So I have had some questions come in, and Roger, you're going to laugh because the first question I literally got back in May from my supervising physician. So it's about the RMS, and I'm curious to hear your take. With the rapid mood screener, the RMS, why were irritability in mixed states not emphasized over elation when mixed states are often more common for a clinician to see in their office?
Yeah, it's a good question. And we had that discussion. The way these items came to be is that we got around a table, we brainstormed. There was we iteratively went through this, and we started off with a much longer list than 6, and that list expanded and contracted based on experience, based on academic publication in the field, and so on and so on. And the balancing act, when you're trying to come up with items, the balancing act is trying to balance sensitivity and specificity. And, if in fact one of the items said, "Are you moody?" Well, that'd be 100% screen positive, but it would have no specificity. And this is always the tension. And we did have a discussion about including some of those mixed features, but we kept them in initially. And then when we started running some analysis with people, because we validated this in people who have the illness, some of those items were not performing that well. We haven't entirely thrown the baby out with the bathwater. If you look at number 3, there is mention of irritability and hyper. That's still there. And there are aspects about this. And number 4, this is the distractibility aspect. But you're right. We don't actually have it there, those mixed features, because of the fact that they didn't really demonstrate the adequate sensitivity specificity. So I think, in fact, when it comes to screening for bipolar, you want to balance your sensitivity, specificity, positive and negative predictive value, which I think we've done very, very well here. Mm-hmm. But it doesn't mean that this is going to diagnose bipolar. I think it rules out bipolar, almost, not quite, but it doesn't diagnose bipolar. Mm-hmm. And I think that the other part I should also emphasize is this has been validated in BP1. And I think we need to be cognizant about more softer bipolar expressions like BP2.
Great response. Thank you. How do you differentiate the 4 A's in bipolar disorder versus the 4 A's in PTSD?
Oh, absolutely. In fact, the question's brilliant, because that's exactly why the DSM did not include those symptoms. Yeah. And the reason they didn't include them is the lack of specificity. Mm-hmm. What the DSM task, the group that worked on this definition, and I've spoken to some of the members, what they had the unenviable task, in the sense that you want to include items that are sensitive and specific. Sometimes in life you can't get both. It's one or the other. It's like when you were a kid and your parent took you to the candy shop. You can't have two, only one. So you have to pick one candy. And the candy that they decided to go with was specificity. And they compromised a little bit of the sensitivity, quite frankly. But that's just a situation they couldn't deal with. I mean, there's no way around it. And I think that is the right decision. So anxiety, agitation, anger, and attentional problems are clearly not specific to bipolar. Mm-hmm. And they're not included in the definition of mixed for the very reason that they don't have sufficient specificity. My point is, though, is that you and I as clinicians in busy office practice, when you're seeing patients who come in depressed, the literature shows, despite the fact they're not specific, they are the most common symptoms in people with mixed anxiety, agitation, anger, and attention. But when a patient tells me that could be rooted, it could be rooted in bipolarity, but it might be rooted in comorbidity or historical events like trauma, could be personality, could be drug and alcohol doing some of that. So that point is really well taken. And this has been carefully iterated and thought through for a long time. Mark Zimmerman is a colleague at Brown in Rhode Island. He has a screening tool for mixed features in bipolar disorder, a measurement tool. And I haven't used it personally. Mark does a lot of great work, and I'd encourage folks to maybe look it up on the internet and maybe maybe try it in your practice. But it's the only tool that I know has been validated for mixed for clinical application. But great question.
Thank you. This one comes from Noelle Riley Filpo, and her question is, how effective and safe is TMS for bipolar depression? I had heard that it was contraindicated for bipolar disorder. Yeah,
good question. Well, first of all, it's not contraindicated. I'll start off by saying that. It's not contraindicated. Now, people work in different hospitals, healthcare systems, jurisdictions, and it might be the case that the local jurisdiction or the provider, the payer, may not have it on their coverage list. But that's a different conversation. It's not contraindicated, but it's not covered, and I know that by a lot of different plans and different organizations. That I do know. I have not seen a head-to-head study, TMS versus ECT, in bipolar depression. Such studies do exist. At least there's been an analysis comparing ECT and TMS in unipolar depression. And I think experienced clinicians are not surprised when they hear this, that ECT is superior to TMS. in treatment-resistant unipolar, but I don't think we really know in bipolar. My own impression clinically, this is just impressionistically, is that ECT is more effective. But ECT doesn't do too well in the court of public relations. It's got a public relations problem. But TMS is not as frightening to people, not as stigmatized. People are more likely to consider it. I don't work in the area of neurostimulation. It's not my academic focus, but I've often believed that TMS may be a treatment that is better at treating not so much treatment-resistant bipolar depression, but treating, depressive symptoms that are not cooperating with medication. But I think it's a treatment that may have some pro-cognitive effects. There's some interesting data hinting at that in unipolar, maybe bipolar as well. So I think that rather than, I know that TMS is often in the same conversation with ECT, but I don't know if that's actually the right way to position it. I've been thinking about this over the years. Maybe it's better to have it a little earlier in the algorithm because it clearly cannot, it clearly is not the same league as ECT. But no, it's not contraindicated, but in patients with bipolar disorder.
This just made me think of a question, and that is, do you foresee a time where TMS might be covered? And I have the same questions for IV ketamine, for things that it's currently not covered for.
Yeah. Look, I think that as an advocate in the space of people who have these illnesses, my hope, my aspirations, they would be covered because I think that's just, fairness and giving people the right to health and what have you. And of course, I don't think anyone would campaign that treatment should be covered unless they're safe and effective and all that. That's clearly going to be the case. So I hope so. And with ketamine, intranasal ketamine is a different conversation because Spravato's
Right.
FDA approved. It is quite heavily priced, unfortunately. That's been a bit of a deal breaker for a lot of people. It's quite pricey. The IV racemic ketamine doesn't have the same degree of long-term data, and it doesn't have large pharma supporting it. So it doesn't have those large clinical trials, but it is very compelling. The short answer is I hope it'll be covered. I think it should be covered because it is very effective, IV and the intranasal. I think the IV has a leg up on the intranasal, quite frankly.
Agreed.
Yeah, it's got a leg up. It really does. That's our experience. But I think these decisions to reimburse involve science, but also involve a lot of non-science variables. And it's the non-science variables that come down to politics and campaigning and advocacy and a bunch of other things.
Helpful. Thank you.
Yeah.
I have a last piece that I wanted to bring up, and this is, I came upon this completely by luck. I got an email from a colleague this morning, but JAMA Network published yesterday a large randomized controlled trial that demonstrates, to me, this feels like big news, no difference between lithium and placebo in suicide rates. I believe, let's see, I think it was among veterans. It was a group of 500. So I'll be interested to see. I haven't dug into the paper yet, but it was just an interesting development that I did not see coming. So.
Well, that's an interesting, I haven't seen that paper. I'm gonna look that up. You've really piqued my interest in that. I'm gonna look that up right after this call. I would say this, that what lithium needed, and maybe this study did this, I don't know the study. Lithium's anti-suicide effects have been replicated largely in observational studies, but we have fewer interventional studies where lithium's been looked at. Yeah. So we look at like big populations of people. It's been pretty consistent that lithium lowers suicide rates. That's pretty consistent. Okay. But again, that's not a controlled clinical trial, right? And so, and what's interesting is that people have also looked at in larger populations, lithium, carbamazepine, valproate, other drugs. Only lithium lowers the suicide rate. But again, those are large data sets. And what we've really needed is a rigorous clinical trial. I'm doing a clinical trial right now, a separate clinical trial. This was also supported by the Canadian government, where we're giving patients, they don't have bipolar, they have unipolar depression, and they're suicidal. everybody's getting guided internet-based CBT. Everyone's going to get CBT. And then half are going to get midazolam, which is the placebo, added to the CBT, which is internet-based. And the other half are getting IV ketamine. And the primary outcome is not depression, it's suicide. And we're trying to see if we can combine CBT with ketamine, can that lower suicide in depression?
Interesting. All right. I believe that may be the end of our questions, unless Ben or Cliff have anything they would like to add.
I think we need to let Cliff ask a few questions. He's probably got some in mind.
I just have one. I have one, and it's quick. A clinician asked me, unfortunately it didn't come up today, but a clinician asked me the other day, and I have no idea what the answer is, so I'm asking you. Is there any evidence to show that brexpiprazole has been shown to be effective with treatment-resistant unipolar or with MDD with mixed states?
I think we lost part of that question, I think. Is it just me?
I can hear you.
Sorry, keep going. Any evidence any evidence that brexpiprazole?
Yeah, you are freezing. That brexpiprazole might be helpful with treatment-resistant unipolar depression or in MDD with mixed states. And I didn't know the answer to that.
I think Roger is a little bit frozen, but he may come back. And funnily enough, Cliff, I can speak to a little bit of that, but I suspect Roger can probably speak more so. There's a randomized controlled, I think it's a phase 3 trial right now for with Otsuka, and it's for a combination of Zoloft and brexpiprazole. You can find it, on the web. So far, my understanding with that is the results are compelling for potential approval. Now, this is kind of borderline, but for potential approval for PTSD, which that's quite unique because we haven't had a big, really anything for PTSD. And of course, me being a trauma specialist, I'm so excited about this. Yeah. But I feel like that's mildly related to your question. It's again, it's not getting into the bipolar angle so much, but I certainly can also speak clinically that I think there's subpopulations where it tends to work really well with the Rexulti does in terms of the fact that it has some anti-anxiety properties on top of others. Hi, Roger.
Hi there. So little Wi-Fi there. So yeah, on the issue of, I think I got most of it. Just guide me if I didn't. On the issue of brexpiprazole, really interesting. Here's a drug that's effective as an adjunct to antidepressants in adults who have major depression when the antidepressant is insufficient on its own. Otsuka has not studied brexpiprazole in bipolar depression. They've studied it in bipolar mania, and it didn't work. Now, I think in some fairness, the placebo was almighty effective in that particular development program for reasons that are, I guess, to be determined. So I don't think necessarily I wouldn't conclude that it doesn't work in mania. I would say they probably had a pretty bad study, is what it sounds like. But anyways, but it hasn't, in fact, they didn't study it in bipolar depression. And I have to say it's, I did speak with Otsuka and the company. I said, you guys got to do a bipolar depression study. And it's interesting because aripiprazole was studied in bipolar depression, and it didn't work in bipolar depression. I think that kind of spooked the company a little bit, to be quite frank. But my own view was, again, it's not my money, so I guess I have the luxury of not being spooked financially with this. But I think that the people who make these types of decisions are people who take into consideration risk and financial investment, this type of thing, and they didn't think the risk was worth it. But although aripiprazole was studied in bipolar 1 depression, didn't work, there is a consensus in the field that probably was because of the way the studies were designed, and I'll go well beyond the scope of today's meeting, but we've learned a lot more about how to do these trials properly, and I think aripiprazole, unfortunately, was the test case, and we learned how to do studies better by the failures of the aripiprazole program. So anyway, it's kind of a long story, but the short story is it just wasn't. They've not studied bipolar depression, and in mania they just didn't work because placebo works so well.
The other thing worth noting, Cliff, that I'm thinking about is the brexpiprazole has some alpha activity that a lot of its colleagues in its class do not have, and so that is something that makes it, I think, unique. And so if I have a highly anxious depressed patient, or especially if I have a traumatized depressed patient, brexpiprazole is something I do often bring in. Not always, but sometimes.
Thanks.
Good question.
Okay,
Great.
does that wrap up our questions, folks? Cliff?
I think it may, yeah.
Okay. Well, Roger, as always, it is a pleasure to have you with us. We really wish you were with us in person, but we hopefully will continue to slog through the adventures of COVID symposia, and hopefully next year we won't be online. So thank you again.
Thanks for having me. Always a pleasure.
Yeah,
Always a pleasure.
It's been great, both sessions. And
Thank you.
The last thing I want to tell folks before they leave for the day is the evaluation is at the evaluation tab at the top of the screen on the conference platform. So please go ahead and open up that evaluation and give us your thoughts, and we do apologize again for the tech issue this morning. We've got things resolved, and you should be also receiving an email from us again tonight to extend our apologies again for that. So thank you. If we're going to see you tomorrow, please check in early, log on early, so we can try to navigate any tech issues anyone experiences, and hopefully not. The email address, if you do have a tech issue, is info, I-N-F-O, at mhaet.com, and we'll have a person standing by to help with any tech issues anyone might have. So thank you again. Appreciate your being with us for a great day, and we'll see you tomorrow.
Thank you. Take care, everybody.
Thanks to both of you.
Bye-bye.